Invitation. It's always a wonderful time to be here. Again, thank you for the invitation. I am Dr. Bowie again. I am going to be talking about sunshine and moles and how to prevent and detect melanoma. I've been working with medical dermatology and seeing patients now for 4 years here in Vermont, and I absolutely love my job, and thank you again for having me. I'll move right into the talk. I have no disclosures. And we'll talk about a few things. There's a few objectives that we want to get through. We want to kind of understand how to calculate a personalized 5-year absolute risk for developing melanoma, which is true to you or true to your patient or true to your friend that you can get access to and figure out how to do on your own. I want everyone to be able to describe ways to decrease their risk of developing melanoma and determine who needs genetic testing for melanoma, because that's not something that we commonly talk about. So again, we'll introduce melanoma and its pathophysiology, who gets it, how many people get it, what are the outcomes, how do people do after they've been diagnosed with melanoma, what is the clinical presentation, how does melanoma look when it's diagnosed, the ABCDEs of melanoma, and the ugly duckling sign. We'll also talk about risk factors for developing melanoma, ways to decrease that risk, and screening recommendations and genetic testing. So we have a lot of things to talk about, so we'll get right into it. So some of the basics about melanoma. A melanoma is a malignant tumor that arises from a specific cell type that's very common in the skin. About 1 in 10 skin cells is a melanocyte. And when this cell type transforms into a malignant cell type, it can cause the type of cancer called melanoma. This particular melanoma that you can see on the screen on the left is 0.23 millimeters deep. So that means that it has left the top layer of the skin, the epidermis, and it's invading somewhere that melanocytes aren't supposed to live. It's going deeper into the dermis to a depth from the top to the bottom of the melanoma that measures 0.23 millimeters. And that is one prognostic sign that we have to say how bad a melanoma is, because they behave more aggressively the deeper that we can measure them. So here's another view of kind of a cut through the skin. The top shows the stratum corneum, which is the most superficial layer of the skin, the part on the outside that keeps the wet from getting in, keeps the in and the out. And then we have the stratum granulosum, the stratum spinosum, and the basal layer. And those all make up the epidermis. And in the basal layer, that bottom layer of the epidermis, that's where the melanocytes live. And what are they supposed to be doing? Why do we have melanocytes? Their job is to make melanin and protect our cells from the sun, because the sun emits ultraviolet radiation, which is dangerous to our DNA. And so the melanocytes make these little packets that it has dendrites, and it sends through these long dendritic projections to the keratinocytes around it, these packets that contain this dark colored protection, melanin, that the cells put it right over their nucleus where the DNA is to kind of like a hat to protect it from the sun so that the DNA doesn't get mutated as much. So unfortunately, we still get genetic mutations despite the melanin in our skin. And these genetic mutations in our DNA accumulate over time, and they kind of build up until you get a bad combination and a melanocyte can go haywire and have dysregulated multiplication and division and turn into a cancer. Inherited genetic predisposition is when we are born with some of these genetic variations, and some of them make us more likely to develop melanoma later on in life. And then we can accumulate more acquired genetic mutations in the DNA, and that's usually from sun exposure. So sun exposure, the sun is an electromagnetic wavelength. Sunlight is composed of gamma rays and X-rays and ultraviolet light, visible light. There's different types of these wavelengths, and ultraviolet light is the one that tends to cause DNA mutations, and that's why we like sun protection, because that's what eventually can lead to skin cancer and melanoma in particular. What's a carcinogen? So a carcinogen is, by definition, any substance capable of causing cancer in living tissue. And what we tend to think about when we're thinking about carcinogens is cigarette smoking. That's the classic carcinogen, is cigarette smoke. But for melanoma, it's actually ultraviolet radiation. And one of every 3 cancers diagnosed is a skin cancer. It's very common, and the main factor that predisposes to development of skin cancer is this ultraviolet radiation, which is almost exclusively from sunlight. You can also get it from artificial tanning beds, but back in 2002, the World Health Organization classified sunlight as a carcinogen. And I remember when they did this and it was like, really? Sunlight? But it truly is. And by definition, it's one of the most potent carcinogens that we have. If you look at a skin cancer and how many mutations are from sunlight, you can actually track a signature mutation that occurs from sunlight, and they're extremely common. So the sunlight is truly a carcinogen, even though it may sound weird to call it one. You know, too much of anything can be a bad thing. There's UVA, there's UVB, and these penetrate the skin to different depths. And so UVA penetrates farther than UVB. UVC doesn't tend to get to the surface of the earth. It's filtered out by the ozone layer, and we're kind of protected from that. But I mentioned briefly about how ultraviolet light can cause a signature mutation. These are the specific signature DNA mutations that ultraviolet radiation causes. You can get thymine dimers in the DNA, and you can get pyrimidine, pyrimidone 6,4 photoproducts. And what these do are cause these covalent bonds in the different bases in DNA. And instead of having this beautiful winding DNA helix, you have a kink. And then things can't attach where they're supposed to, and you get replication mistakes and errors, and it leads to cancer. So photocarcinogenesis is a very common carcinogenic state that we see in dermatology. We see it on sun-exposed skin, and it's just from decades of UV exposure over the years, an accumulation of numerous UV signature mutations that cause changes on a single cell basis. And eventually there can be a clonal expansion of one cell that's got too many in the wrong combination and bad luck, and you get malignant transformation of that cell. So, you know, we talked about what this looks like in the DNA, but what does it look like on the skin when we're just using our eyes and we can actually see it? And so seeing photo-damaged skin is something that we don't think about consciously, but, you know, looking at this individual, how old does this person seem to you? If you were just going to guess, would you say, are they a 40-year-old person? Are they in their 50s, 60s, hundreds? How old would you guess this person is? Just, you know, if you were walking down the street, you would probably say they were pretty old. And I would be surprised if your gut feeling was actually 62. But this American Indian woman is actually 62 years old when this photo was taken, and she's just had extensive photo exposure, and it causes these deep furrowing folds and solar elastosis and certain visual cues that tell me that she's had a lot of sun and she's at more risk of a skin cancer than someone without these findings. And it just looks, it prematurely ages people because the skin's not healthy, and unhealthy skin looks old. And so how about this individual? So the kind of the flip side of the coin, but how old does this individual seem to you if you were just walking down the street? You might say, oh, this person's in their 40s, and then you'll double take when you find out they're 91 and very sun protected. And this is obviously a simplification because your genetics take a huge role in this. But this person was very photoprotected throughout their life, as opposed to the prior example. And there's just a visual recognition of that and the health of the appearance of their skin and how other people can see that and observe that. In one person, you can have this. This is an extreme example of someone who was a delivery truck driver for almost 30 years and had chronic UV exposure through the window of the car glass, which happens, which is why we always recommend wearing sunscreen daily, even when you're not outside, because it comes through windows. But on the sun protected side of the face, you can see this person is far more youthful in appearance than on the side that was getting the sun exposure through the glass, and looks prematurely aged on that side. This is just another example of the same kind of thing, of an individual who had their desk the same place with a window right next to their desk on the same side for decades. And caused a lot of wrinkling and damage to that side of the face alone. This is a twin-twin study. This study showed the visual difference in twins in terms of their appearance, their age that was prematurely aged from and attributed to excess sun exposure. So these are two different people, and the twin in A, the one on the left, had about 10 hours less sun per week than the twin on the right. So the twin on the right was more outdoorsy and didn't wear enough sunscreen or hats, and got a lot more DNA damage, and it's visible. It's very obvious. And so the perceived age difference, when they did a blinded comparison and asked people how old does this person look and showed different photos, they found that the perceived age difference from about 10 hours excess sun per week was 11.25 years. And so one advantage of sun protection is that you look younger because your skin is truly healthier. So this is, again, this gentleman from the past who was the truck driver, and the image was just split down the middle and mirrored, and you can see the no sun half of the face looks like a much younger person than the side that had a lot of sun. And it's just very, very dramatic what you can do for yourself by being good about sun protection and avoidance. Not only cosmetically, but what I care about is skin cancer prevention. And so I cannot hammer that home in a picture says a million words. And this is just very effective and very startling, the contrast there. So now we'll move on to the epidemiology. How bad is melanoma? How common is melanoma? So back in 2018, invasive melanomas represented about 91,000 cancers in the United States of America. That's only 2% of all skin cancers. And a lot of people get melanoma, they use melanoma interchangeably with skin cancers, but it's actually one of the less common skin cancers. By far and away, the most common type of skin cancer is basal cell carcinoma. And luckily, that's a much less aggressive form of cancer. But basal cell carcinoma is the most common type of cancer, period. And then squamous cell carcinoma, and then third comes in melanoma. But unfortunately, even though it's much less common than those other types of skin cancer, it makes up almost 75% of skin cancer related deaths. And so even though it's uncommon, it is more deadly. And that's why we talk a lot about it. This is kind of the frequency and the rates of death for invasive melanoma from 1992 out to 2017 in the United States. And you can see in the light green that the frequency of melanoma diagnoses is increasing, and people are developing melanoma more often. But luckily, with advances in treatment, people tend to be dying less often from it. And so we're getting better at treating melanoma, and we're finding more of it. So these are 2016 estimated cancer rates. And you can see in men, melanoma accounted for about 6% of cancers, whereas in women, it was only 3%. And this is excluding basal cells and squamous cell carcinomas, which are, again, super common. This is actually Vermont specific data. And in Vermont, between 2011 and 2015, melanoma was the only cancer that had any significance out of all the ones listed here. And unfortunately, it was significantly increasing in frequency. And that's still the case out through 2017. So again, this just shows that melanoma of the skin is increasing for females. This shows where females in Vermont were being diagnosed with melanoma between 2011 and 2015. And the Southeast region had a higher incidence, so more people per 100,000 were getting melanoma in that region, but also the Burlington metro area is higher. This is 2013 through 2017, all comers. And again, the Burlington metro area is a little higher than other areas, but you can go onto the SEER database and you can see for your specific county throughout the US what your specific rates are for melanoma. This is the incidence rate for Vermont by county again, and you can see that Chittenden County, where Burlington is rising. Unfortunately, we're getting more melanomas in the Burlington area. And that goes along with the historical trend where we were seeing kind of a stable amount of melanomas per 100,000 residents, and then it's kind of shooting up. It appears to be becoming more of a problem for more people. And then what are our melanoma outcomes? How do people do once they get one of these diagnoses? And it really depends on how thick that melanoma, we talked about if the melanoma leaves the basement membrane of the epidermis where it's supposed to live and starts invading deeper where it's not supposed to be, that Breslow thickness can help us determine how bad of an outcome it's going to be. That's one of the criteria that we can use. And if that Breslow thickness was less than 1 millimeter, people do really well. People do, with a 5-year survival rate of about 94%. And those rates tend to be improving with time, not worsening. And this is older data. But once the cat's out of the bag, if there's metastases already, lymph node metastases, then people only have about a 5-year survival rate of about 63%. And again, it's better now. But distant metastases, if it's gone past the lymph nodes into another organ, then it's really low at about 17%. This next slide kind of tells us, what do people think about the sun? I talked about how the sun is considered a carcinogen by the World Health Organization, but do people recognize that? And, it looks like the blue's good here. So in Vermont, the blue kind of shows that most people think and recognize that the sun is causing skin cancer. So we're kind of in the know here, and that's a good thing, but I think we could do better because this only is about 73% of people saying yes. So there's, a quarter of people that don't recognize that as a true risk. So there's always room for improvement. So how does race factor into this type of skin cancer? And it really does, primarily because of skin tone, skin complexion, and the amount of melanin, those melanin packets that those melanocytes are pumping out and protecting and putting over every nucleus that's being exposed to radiation. How much melanin do you have is a big factor in your risk of developing melanoma. And it tends to be a disease of people that don't have enough melanin, and that's white individuals with a fair complexion, and especially redheads and people that are albino that just don't make enough melanin or any melanin. So the lifetime incidence of people that are very fair is 1 in 40, whereas if you have a very dark complexion and people of skin of color, it can be more like 1 in 200 or 1 in 1,000. And so that is a very good thing for people that have a very dark complexion, but unfortunately it can be harder to find because it hides. It's not as stark of a contrast because melanomas tend to be dark in color. And if your skin also is, it can blend in and you can't identify it. And it can also happen in body sites like the palms or the soles or in the mucosal membranes where it takes longer to identify. And then the outcome is actually worse because it's progressed. And so even though it happens less frequently in skin of color, they're more likely to have advanced disease once it's found. Okay, so how about sex? How does that play into melanoma? And there are differences between men and women for this. And men tend to, over a lifetime, develop melanoma more often. 1 in 33 men have a lifetime risk of developing melanoma, whereas 1 in 52 women do. But it is the #1 cause of death from cancer in young women. So I think it's 25 to 35 is the #1 cause of cancer death in women. And so it's still strikingly a bad thing for females, especially young women. So here are some of the clinical patterns of melanoma. And the one on the top here has a superficial spreading type of growth where it goes thin and stays around along the epidermis mostly and goes wide. And so that's the most common thing we find on the legs of women and on the back of men, and it's the most common subtype of melanoma. You can also have nodular melanoma that makes up about 15 to 30% of melanomas. These are elevated and they have rapid invasion and they get that thick Breslow depth, and that again is a bad prognostic indicator, and they tend to be more aggressive. There's also lentigo maligna melanoma, which is somewhere between 5 and 15% of melanoma diagnoses. These tend to be pretty slow and indolent, and they tend to be brown to black macules and patches, usually on very heavily sun-damaged skin, on the face, the neck, and the arms. And then there's acrolentiginous melanoma, which is between 5 and 10%. And that typically is a poor prognosis, and it's usually presents pretty late when it's identified as actually being a melanoma. And then the one that scares me the most is amelanotic melanomas, which luckily are less common, but they don't have pigment to tip you off. And they look like a pimple, or they look like something that's just a little a flesh-colored mole. And these ones are the ones that scare me because I don't want to miss them. And they tend to be much harder to find. But luckily they're very uncommon. But they have other things that we use to be tipped off that there's something that needs a biopsy there. So again, these are the amelanotic melanomas, where they just kind of don't have deep pigment patterns in that brown and that black danger sign color. And so there's more of a propensity for people to write it off as being more of a benign process going on. There are some dermatoscopic findings when we get our microscope out and do a skin check that can tip us off to an amelanotic melanoma. And then a lot of the history, it's getting worse instead of getting better, like a pimple would. It's bleeding even though you didn't shave over it or injure it. And there are things that can tip you off to amelanotic melanomas, luckily. I think we already discussed this very briefly, but the distribution of melanoma, where we find them in men and women, tends to be different. The legs tend to be the most common location in women, whereas the trunk tends to be more common in men. You can get melanoma in the eyes, and that's something that our colleagues in ophthalmology are very good at identifying. But there's some areas that you don't necessarily think about for melanoma, but you can still get melanocytes there because of embryogenesis and where melanocytes travel through that process. But the GI tract, the CNS, other organ systems can be the prime where it starts. It's not always the cutaneous skin. Subungual melanomas can look like these dark strips, which are usually from something like a benign process or from drug-induced pigment changes. They can also be because of melanoma. And I was just talking about these forgotten melanoma locations like the mucous membranes, the nasopharynx, the larynx, the vagina, urethra, anus, and rectum. And those, again, they have delays in diagnosis, and that means that the prognosis is worse. Here's some locations in skin of color, and the palms and soles, mucous membranes, and subungual locations tend to be more common. So what are we looking for if we're doing a physical exam? Or what is your doctor looking for if they're doing the physical exam? And so recognition of an early melanoma is key before it gets really thick, before it spreads to the lymph nodes or other parts of the body, when it's very curable. And so we use some criteria just to help people think about it, and it's the ABCDE criteria. And then a new or changing mole is super important as well. And interestingly, about 80% of people that come in and get a diagnosis of melanoma knew there was something wrong. The dermatologist only identifies them without the patient having been aware of the lesion about 20% of the time. And so the patients know their bodies. Listen to your patients if they're concerned about a spot. Sometimes that's your only clue. So going through the ABCDEs, A is for asymmetric, B is for border, C is for color, D is diameter, and E is evolution. And we'll all go through all of these in more detail. A means that they're asymmetric such that one side doesn't match the other side if it was in a mirror. B has, the one on the left is a perfectly round shape. The borders are as smooth as they get, and not every mole is completely regular or has perfect borders, but the border, this is just a clue that you can have jagged, blurred, irregular, notched, or missing borders. And then all of the images on the right show examples of melanomas with abnormal borders. Colors is another warning sign. Colors more than 3 gets our attention. And so if there's red, then we think about the immune response or vasculature. If there's white, we worry about focal regression, which is a prognostic sign. And then if there's blue, we worry about the depth of invasion, because it starts having this blue hue to it if the melanin gets too deep into the dermis with a Tyndall effect. So D is for diameter bigger than 6 millimeters, which is a pencil eraser diameter. And that is another sign that can tip you off to something that needs to be looked at. And E is for evolution, and that means any change. That just means that it's increasing in size, color, it's changing. It's painful, it didn't used to be. All of a sudden it's tender, it's itching, it's bleeding, it's raised. That's something to be on the lookout for. But the most important one is the ugly duckling sign. And this one is not part of the ABCDEs, but it is very effective. And that just means you're growing something on your skin that doesn't belong. It doesn't match the other spots you grow. If there is something that just doesn't look right for your skin, then it probably deserves a closer look. The ugly duckling can be like A, where it's a bigger, darker one in a sea of very similar gray colored ones. It can be a lighter one in a sea of darker ones, or it can be the only one in a sea of nothing. The ugly duckling sign just means that it's not like the rest of your skin. Something different is happening there. So here's a couple examples of ugly duckling signs, and some more ugly ducklings that just don't match the skin on that person. And almost always a melanoma is gonna be an ugly duckling. And when we look at all of the melanomas that we diagnose at the University of Vermont, it's very uncommon to have a melanoma that's not an ugly duckling. Other warning signs: bleeding, crusting, ulceration, even though you didn't injure the site. So, you know, doctor, I have a suspicious looking mole on my shoulder. Not everything that looks funny is a melanoma, luckily. There's a lot of mimics and there's a lot of things that are 100% benign that we don't have to worry about. And so most of the time, if you come in, you'll probably get reassurance. Oh, this is a dermatofibroma. I'm so happy. It's not a melanoma. And we see a lot of seborrheic keratoses because they break a lot of rules. But you know, just because it's breaking one of those A, B, C, D, E criteria, or it's an ugly duckling, doesn't make it a melanoma. It just means it needs another look. So contact your dermatologist, your friendly local dermatologist, and we're happy to look. It takes, you know, it doesn't take long. We're trained in pattern recognition. We have years of training looking at our 10,000 examples to be able to tell that cow from a horse. It's hard to explain how you know what it is. Try explaining verbally how you know a cow is a cow and not a horse. It's hard to do, but you just know. And it doesn't take time. It's an instant process. So you're looking for that experience and that pattern recognition. We also have tools at our disposal that we can help us be more accurate with making that judgment call. And my favorite one is my dermatoscope. I absolutely am stranded if I didn't have it. And so we have lots of backups in the clinic. When one runs out of batteries, then you have to run and get your other dermatoscope. But there's other things that look like they could be a melanoma, like the bottom center photo, that are not melanoma. There's pigmented basal cell carcinoma, which is still a type of skin cancer, but so much more curable and less concerning medically. Seborrheic keratoses, which we see all day, every day, because they're constantly breaking rules and changing size, shape, color. Very benign though. Hemangiomas can sometimes thrombose and clot and turn black, and that can be startling. Lentigos, you can get ink spot lentigos. You can just have so many sunspots, it's hard to decipher which ones are okay. And if you have some that kind of need a special look at, it is a marker of skin damage. And then just regular moles. So what do we do for diagnosis and treatment? Again, I always look with my dermatoscope if I'm at all concerned, and sometimes just to get a sense of a person's skin. When I have suspicion, I we'll do a biopsy of the skin where we numb it up with local lidocaine, and we just want to know what we're dealing with. So our intention is not to cure, but to find us a diagnosis. And then we might, once we know if there's a melanoma there or not, we might do the excision ourselves as the dermatologist, or phone some of our colleagues in surgical oncology or medical oncology, depending on how severe the case is. And one thing that's changed over the years, you know, back in the early 1900s, we used to do 5-centimeter excisions for a melanoma. And then it got, you know, more is better, more is better. It got out to 15 centimeters in the 1960s, which is 8 inches for a melanoma diagnosis. And it was very disfiguring. And luckily, people said, is this necessary? And the answer was no. There's been hundreds of studies now that we can do more like 5 millimeters to 2 centimeters instead of 15 centimeters with much less disfigurement and the same cure rates. And so, you know, we need to treat appropriately and cause the least harm. Do you know harm? And that's one thing that we've really improved, is our ability to treat them effectively and not cause unintended problems that don't have any advantage to them. And then we have a lot of new systemic treatments like BRAF inhibitors and MEK inhibitors and immunotherapy and things that are changing people's lives and saving lives. And we're getting better at helping people treat their melanomas when it happens. So looking at some melanoma risk factors, there are genetic factors factors, what you're born with, the hereditary factors, which make up about 14% of the risk for melanoma in any given individual, environmental factors, which is almost exclusively sun exposure, and then the phenotypic expression of those interplay, the genetic and the environmental interactions. And so we'll go over some of those risk factors and their relative risk, but if you have a lot of moles and you didn't have a lot of sun protection when you were a kiddo, then you're going to make more moles, because when you're growing up as a child, the number or the amount of sun you're getting when you're really young dictates how many moles you grow. And so if you have more than 100 nevi, that means that you probably should have had more sun protection when you were really young, and it means that your risk of melanoma is 10 times greater than someone who doesn't have that many moles. And that's something you can't really change anymore, but it means that in the past, you had way too much sun, unprotected sun. If you have over 5 atypical melanocytic nevi, then you're about 5 times increased risk for melanoma. And the atypical nevi just don't look right. They're breaking some of those ABCDE rules, but not bad enough. They look like they've turned into melanoma, and that's a judgment call. And then the next thing is solar lentiginase. And these are the freckling that you get, the sun freckling, or the liver spots, people used to call them. We call them solar for sun lentiginase now, because we know that it's not the liver, it's the sun doing it. And the more that you have, the more excess sun that your skin was exposed to. And some people are not as good about protecting their DNA than other people and tend to freckle like this, and that increases their risk of melanoma. And then just knowing that someone's had a melanoma in the past increases their risk of having another one, or having a family member, a first-degree relative with melanoma. You know that the genetics are similar to a degree, and that increases their risk. So there is a melanoma risk factor algorithm that's based on 7 factors that we know can increase the risk of melanoma. For instance, hair color, like I talked about, redheads, blonde people are increased risk as well. Skin type, so if you tan easily, you're less risky, but if you can't tan and you burn really easily, you're higher risk. Family history, freckling, how many moles, number of large nevi, and history of sunburns. And this can give you a general sense of what your personal risk is for a patient. And it's kind of a fun thing to try, but it's the NIH National Cancer Institute Melanoma Risk Assessment tool if you want to check it out. And it can give you your risk of melanoma in the next 5 years based on those factors. And so when I did it for me, my personal risk is 0.03%, so fairly low, so I'm pretty lucky, but I'll take it. And then let's go on to how we can all decrease our risk of developing melanoma. The environmental factors that we can change. And that's intense intermittent sun exposure, like a lot of people in Vermont get when you finally get a nice day after a long, long winter. Chronic sun exposure in like really tropical places where you're out every day, and it's a chronic thing, enjoying that lovely sun. And then that's residence in an equatorial latitude. PUVA, which is a type of treatment that we can sometimes treat other types of skin cancer or skin conditions with on purpose, but it can increase your risk of skin cancer. And then tanning bed use, especially if you're under age 35. Those are things that are modifiable, meaning you can change what your personal risk is. And I used to get a lot of sun. A lot of my patients tell me about how awful they were when they were little before they knew any better, and I'm right there with them. I have been in a tanning bed, but now that I know better, I make little changes, and I've been able to modify all of these things for myself. And I'm much healthier in my skin now than I used to be. So again, things you can't change. You can't change your gender. You can't change your age. You can't change, though you can change the appearance of your age with sun protection, which is a little different. But you can't change your personal history of melanoma, your family history of melanoma, or your genetics. You just can't change those things. You can't change your race, your skin type, how many moles you already have, how many atypical nevi you already have. If you have congenital nevi, or if you're immunosuppressed, you usually can't change any of those things. But you can change your exposure to the sun. That is something that you still go outside. You still enjoy the outdoors. Being outdoorsy is super healthy. That's not what I'm saying. What I'm saying is you do it in a healthy way for your skin as well. You go out hiking, you go out boating, but you do it with protection from the sun so that you can still do that in a safe way and never go indoor tanning. So melanoma prevention, I cannot say it enough, things you can change. About I'll say it another way, about 9 out of 10 melanomas were preventable if that person had been better about their sun exposure in their past. They probably would never have gotten melanoma. And what you do now matters. Even if you've already had a melanoma, you can drastically change your risk of getting another melanoma by what you do starting today. And so your habits can impact the future for you drastically. Again, never go indoor tanning. Base tan is not a thing medically. Medically, it means that your DNA was trying to protect itself by tanning, but you've already had enough DNA damage to say that it needed that tan. And so it is not productive. Your risk of melanoma increases by 20% if you have ever used a tanning bed one time use. And but it is dose dependent. So every additional time you go increases that risk of melanoma, and you can get it really early into tanning bed users. It's tragic. Seek shade. This is becoming far more socially acceptable, and you see it so much more at the beaches where people bring shade with them, and I am a huge fan. Tents are amazing. Umbrellas. Use your hat, wide brim hat. Don't forget your ears. Use the UPF clothing, and people are like, oh, it's so hot. But if you get the right one, it's wicking and it's actually cooling, and it makes you feel cooler than if you weren't wearing one of those sun protective shirts. They have laundry additives that you can put to the clothes you already have. They have, just a regular set of long sleeves rather than the UPF clothing. Pants, don't forget your eyes, wear sunglasses, lip protection. I always try and make a little change every year for my New Year's resolution or what have you. And sunglasses are my current change. I'm trying to be better about remembering to bring them with me, and always having sunglasses when I'm out and about. And so we do recommend sunscreen every day because, again, it comes through the windows. You get stuck outside you weren't expecting to be, and you can get burned. It should be broad spectrum and protect from UVA and UVB. Your sunscreen should be. SPF, I'm always fighting the myth that anything over SPF 30 is a waste. Not true. People it's an exponential increase in your protection, but that increase from 30 to 50 is real. In real life use, it gives you less of a sunburn in the way people actually put it on in real life. 100 is the best. If you can find 100, use 100. If you're doing the work and putting the sunscreen on, why use a less effective sunscreen? Get 100. And put more on. So usually, the one people don't tend to put enough on is the spray where you mist it. It's not perfume. You actually have to go slowly and spray that sunscreen on and then rub it in. I know it's a lot, but if you're using a lotion, they say to use a shot glass full. So that's a lot of sunscreen, and most normal people are not putting that much on because they're not aware. And so that's a whole nother reason to just choose a higher SPF and get a little extra boost, because it needs to be reapplied every 2 hours when you're out. And so, normal people are not putting a shot glass full of sunscreen on every 2 hours like clockwork. And so you choose a higher SPF and just do your best. That is all we can ask. Be reasonable and be as safe as you can with the sun. There's lots of things where you can try and work sunscreen into your daily routine. I'm finding more lotions with built-in sunscreen, which is phenomenal. It makes it a lot easier for us. Oh, another thing with the sprays is to make sure it's well ventilated. I worry about inhalation and getting it into the lungs. There's lots of kinds of sunscreen now. You can find it not only in the lotions and the sprays and the foams, which we see commonly in the drugstore, but you can find it in a gel. You can find it in aftershave, in bar soap, liquid soap, and I really like the powder, and just regular makeup. And so, if you're not a lotion fan, then try and explore different options. They're out there. And check the Cancer Center Foundation for their seal of recommendation. And they have a website where you can actually look up the brand that you have and see if it's one that they vetted, because they do an excellent job, and they can point you in the right direction to some very highly reputable ways to protect yourself, including film on windows. There's even vitamins that you can take that most people are not aware of. Niacinamide and Heliocare are things that do not require a prescription, and there is evidence showing that they are sun protective, and they can help prevent skin cancer. There's some other fun things that you can try out. People are constantly making apps, and you know, there's wristbands that change color if you just to remind you to do that reapplication. But there's different things that you can do, and you can be creative. The USPSTF for skin cancer screening I wanted to mention, because I have a lot of patients that actually are really low risk for skin cancer that want an annual skin exam. And the only people that we truly ask to make time in their lives to get that annual skin check are people that have had a melanoma or a skin cancer already, or people with a first-degree family member with melanoma type skin cancer. Those people, we ask them to make the time to come in once a year for a head-to-toe skin check. Everybody else probably doesn't need a head-to-toe skin check every single year. The problem parts are places where you've had all that sun, and there's just not enough people to do all of those skin checks effectively. And you know, there's other organs that you don't get an annual check for, like your kidneys. You don't get an annual kidney check every year, but your skin, if it's a healthy organ, it probably doesn't need an annual head-to-toe skin check every year. That being said, if you've got something breaking the ABCDE rules, or if you've never ever had a head-to-toe skin check, then you know it's something that might be warranted. If you've had a lot of the things that we're talking about, then by all means. But not everybody needs an annual full body skin exam every year. And then lastly, I think we'll talk very briefly about genetic testing. And this is people that are born with a lot of risk inherently. And there's the American Academy of Dermatology's guidelines that came out in 2019 for referral for genetic counseling for possible germline genetic testing in select patients. And this is based on consensus opinion and case studies. And the criteria are that if you've had a family history of an invasive melanoma or pancreatic cancer, and if there are 3 or more affected family members on one side of the family, then that can qualify you. It's like the rule of 3s. If there's been like a mom with a melanoma and her sister with pancreatic cancer, and you've also had a melanoma, then your family might be at higher risk because of your genetics, and that might qualify you to at least chat with a genetic counselor about the options for genetic testing. So if a single individual has had more than 3 or more invasive melanomas, or if it was really early in their age, so if they were less than 45 years old, that's an early onset tumor, and that might be genetically related. There's these things called MBATEs, and that can be a different qualifying factor, and that would be something that you would get back from a pathology report if you had a biopsy done and it came back showing an MBATE. Then that is another thing that might mean you should get genetic testing, and it has associated cancers in the BAP1 tumor mutation syndrome, where you can get mesotheliomas, meningiomas, uveal melanomas, be really sensitive to asbestos, and just be a higher risk patient that might benefit from genetic counseling. And these are some examples of MBATEs, the melanocytic BAP1 mutated atypical intradermal tumors. These are not in and of themselves melanomas. They just mean you're at risk for melanoma. And they can look very bland, like a normal mole, but luckily they're very extraordinarily rare. So this is not something we see back. Even as dermatologists, we rarely see this. This is the cancer syndrome assessment tool that I use in clinic, so it's a little more involved, but you can go through all of these criteria for different kinds of cancers, and as soon as you hit 3, you say, okay, well, maybe we should talk to genetic counseling and see if you want to get genetic testing, which we have at UVM Medical Center, and we have some lovely genetic counselors, and they have a long time to talk about what the implications are, any questions you might have about it, and they have pretty long appointment times, which is phenomenal, and they can talk about if it's covered by insurance and what have you. But you don't have to meet strict criteria. They're happy just to see, you know, to talk about if in the future you want to do that. So I think we'll stop there, and I'll just say thank you again for inviting me to do this talk. I always have a great time, and I'll take any questions. Thanks.